Okay, students. So this talk is on non-accidental injury, and over next 10 minutes or so, what we will do is define what is non-accidental injury, and then I will also discuss with you how to diagnose non-accidental injury, and from exam point of view, discuss few classical features of non-accidental injury. They may not be common, but they are more specific for non-accidental injury. So we'll discuss what is their pathology of those fractures. So non-accidental injury actually is a part of a broader umbrella term called child abuse. And child abuse in simplistic term means any deliberate harm inflicted on a child by any caretaker. So any interaction or even lack of interaction. So now negligence is also part of the child abuse. So any interaction or lack of interaction between family member or caretaker which results in non-accidental harm to child's physical, and now we add developmental state also, which is part of the emotional states, become a part of child abuse, which is a much broader terms. The other terms which are synonymous with this, battering child syndrome or child battering, non-accidental trauma, or shaken baby syndrome, these are all used by different people for the same problems. So by definition, as I told you, child abuse is a big term, and one part of this is the physical abuse, and which we will discuss today, which is a non-accidental injury, which is a physical part. We will not discuss the sexual abuse and the emotional abuse and the neglect part today. So we're talking today mainly about non-accidental injury. And why it is important, as you being an orthopedic surgeon, you probably will be the first person to interact with these. So you need to know how to recognize them, and then how to document them, and eventually it will be a team approach for management of these injuries. So as I told you, non-accidental injuries may be an act or not realizing the act, which mean a neglect. So it include injuries that result from deliberate action against a child or failure to prevent that injury is definition of a non-accidental injury. What does it involve? It can involve the whole system, but the commonest is soft tissue injuries. So you will see different bruises and cuts of different stages of healing. And the second most common is the fractures. And we will discuss today mainly with the fractures, although the fatality involved with non-accidental injuries mainly because of the head trauma, but we'll not discuss that today. So historically, Caffey was first to describe 6 children with chronic subdural hematoma and 23 long bone fractures. And then it was in 1962 when Camp actually coined the term battered child syndrome, which is also used for this particular entity. There is a great increase in medical and public awareness, and now people know about it and they report it. So it has improved the care for these children. So how do we diagnose a non-accidental injury? Actually, there is no diagnostic test for non-accidental injury. The diagnosis is made on a balance of probability, a careful exclusion of other possible cause, especially the simple accidental injuries, and few medical conditions you should know of, which we will discuss later on, before labeling a condition as a non-accidental injury. So overall, how do we diagnose and manage non-accidental injury? It is just like any orthopedic condition. You take a detailed history, you do a detailed examination, you do a few investigation, and then you treat it, and we will go through that in the same formats. In the history, you assess the risk of a child who can be abused, risk of caregiver who can abuse children, and a social environment where children can be abused. Examination include the whole general physical examination and specifically the ortho examination. So what are the risk factors for non-accidental injury? Younger children, firstborn children, unplanned children, premature infants, children with some disability, stepchildren, single parents home, unemployed parents and abusive parents, parents who use substance misuse, families with very low income, and children of parents who previously abused. So if the children were abused previously and they are parent now, they are more likely to abuse their own children. So what do we do in the history? We have to first ask these questions. Has there been a delay in seeking a medical treatment? Is the parent reluctant to give an explanation for the injury. Is the injury consistent with the explanation given? Does the story changes between different caregivers? And does the story changes between child and the caregiver? So you have to be a bit suspicious when you're doing the history and make sure that the, the injury is matching with the history you are seeking. And then on physical examination, you carefully search for sign of acute and chronic trauma. The bruises in the skin, are they different stage of healing or they are on the same stage? Examine from top to bottom, examine for skull trauma, palpable frontal, if open, consider fundoscopic examination for retinal hemorrhage. Examine rib cage and abdomen in extremities. Examine carefully for soft tissue and bony injury and genitalia if you're suspecting a sexual abuse. Then come to a specific pattern of examination. Actually, the commonest fracture are very similar to the common accidental injury. So although we will discuss some specific fracture with the child, non-accidental injury, but commonly you see the common fracture. You must rely on other factor, your history and physical examination to corroborate. So 2 and 2 must be suspicious that you're thinking this 2 and 2 not matching 4, it is 5 or 3, and then you have to be suspicious of non-accidental injury and then look for the specific features. So what are the specific feature when you're looking for the x-rays? There are certain with the high specificity, certain with the low specificity, but high specificity doesn't mean they are more common. If they are there, then you should be strong suspicious. And these are metaphyseal corner lesion, which we'll discuss a little more in detail, posterior rib fracture, scapular fracture, spinous process fracture, and sternal fractures. And moderate one are multiple fracture, fracture of different age, epiphyseal separation, vertebral body fracture, digital fracture, complex skull fracture. And the common but low specificity are the long bone fracture or clavicular fracture or linear fracture of skull, which can happen even in the accidental but commonly seen in non-accidental injuries. So let us go through some of these x-rays. So multiple forearm fracture, some are healing. You can see this fracture is showing some healing here, and whereas the other fresh fracture is there. So multiple fracture and different stage of healing, you should be suspicious of that. These are the typical lesion we discussed, the corner fracture, and we will discuss these a bit more in detail. These are supposed to be more specific for non-accidental injury. So see another corner fracture seen in a child in a lower end of the femur. And what are the corner fracture? Initially, we used to believe that when we shaking a child, that mean traction and torsion type injury causes avulsion of this corner of the metaphyseal and causes fracture. Over the period, actually, we have changed our understanding of these a little bit. Now we know that the bucket handle fracture and corner fracture actually are the fracture of the similar nature or same spectrum. And where did this fracture occur? This fracture occur in primary spongosa. So remember, this is not an epiphyseal injury. This is not a physeal injury. This is a metaphyseal injury. The freshly formed metaphysis, the primary spongosa, where the fracture line goes like this. And what happened in this fracture line is sometimes you can't see the middle bit of the fracture. You only see corner because the corner are bit more lower or protruding bit more lower here. So you can see the two corner fracture and you can't see middle bit because of the x-ray overlapping. But actually, this is a through and through fracture in the metaphyseal. So remember the corner fracture and the bucket handle fracture, which are classical or pathognomic of non-accidental injury, actually are in the primary spongosia, transverse fractures. And since some bit of the bone is more protruding, you only see corner and you miss this middle bit because of the x-ray projections. And the same is being shown here, how the corner fracture are seen. If you don't see the middle bit, you will only see the corner. So here, see this bucket handle fracture. If you can see and through, slightly different projection, you can see the bucket handle. And if different projection, you can only see a bit of corner fracture. So nowadays, actually, we define these both together as a CML or classical metaphyseal lesion, and which is either a bucket handle or metaphyseal or a corner fracture. So remember, these are the very specific fracture for non-accidental injuries. This is another of a bucket handle fracture, which is being healed, and you can see a lot of callus formation, and you should be suspicious of these kind of injury for non-accidental injury. Other one is a posterior rib fracture. And how does this happen? This happen by anterior posterior compression of the chest. And when you causes this, you see classically a fracture in this region on the posterior aspect of the chest. This you can have to look very carefully in the x-ray, because in children you can easily miss in this normal chest x-ray, but you should be suspicious of this. The other common fracture are the long bone fracture in a non-ambulatory child. So be very, very, very suspicious if somebody is not ambulating, that means is less than 1 year of age or 1.5 years of age and having tibial or femur fracture, then suspicious that this is a non-accidental injury. So that is about the getting a history, the physical examination, and few typical X-ray finding. How do we investigate these children? So anybody who you suspecting of non-accidental injury, especially children less than 2 years of age, the next investigation should be skeletal survey. And skeletal survey is very different than this babygram we call, where the whole baby is x-rayed in one film. That is very difficult to interpret and very difficult to recognize those fracture like a posterior rib fractures, which you can easily miss. So there is no role of babygram. You should have a skeletal survey of these children, especially less than 2. Between 2 to 5, you take your own discretion whether history is matching or not. But after 5, we normally do x-rays of the involved part, because skeletal survey then has got very little value. But definitely less than 2 in all the cases suspicious, and 2 to 5 your own discretion. Do we need some other investigation? Yes, other than plain x-ray. Sometimes you need bone scan, because those rib fracture may be very difficult to find, and similarly the sternal fracture. Sometimes you need a bit more investigation, especially if it is a physeal separation, classically seen in distal humerus. This we will discuss in our elbow injury section, how to differentiate a supracondylar, a physeal separation, and a elbow dislocation. But sometimes you may require an arthrogram to differentiate these features, and these are extra investigation you may require. So once you have done your history, physical examination, you have found the classical X-ray features, or you are suspicious because of the age of the child and sustaining some long bone fracture, but you should always consider the differential diagnosis of non-accidental injury. First thing is, could this be a normal accidental injury? Could this be a birth trauma, osteogenic imperfecta, Caffey's disease, rickets and scurvy, congenital syphilis? The child may be not very sensitive to pain, coagulation disorder where you can see multiple bruises, and some malignancies you should rule out. And in children, sometimes you can get confused of the fracture because of the normal radiographic variant, so you should know about them. So treatment of non-accidental injury is always like fracture management is like any other fracture, but you should admit these patients even if you normally would not have admitted in a normal accident. Then you should discuss it with either a number of multidisciplinary team or with your colleague, and then report this injury to relevant authority to take action. So admit, discuss, and report, and treat fracture on its merit, what you would normally treat. So in summary, there is no diagnostic test for non-accidental injury. The diagnosis is made on balance of probability, careful exclusion of other possible cause, especially the accidental injury and some pathological fracture should always be ruled out. And I think that's all about non-accidental injury. In the exam, you should know when to be suspicious, especially with the history. In physical examination at different stages of healing of different fractures, and in x-rays, you look for classical sign of those corner fracture and bucket handle, and suspicious when you see a common fracture pattern, but in the younger age group. Thank you very much.